Hello, we're going to talk about medications for pulmonary disorders. Now, I'm not going to spend any time on the anatomy, physiology of the respiratory system, or the functions of the respiratory system. I think that you all know those by now. I might just remind you that um, the upper respiratory system is controlled by the autonomic nervous system, well, both the upper and the lower. Um, the upper primarily by cholinergic and adrenergic. The lower can be affected more by uh, the adrenergic, especially beta 2 receptors in times of stress. Um, and then at rest, the parasympathetic nervous system typically comes into play. So you want to think about, bronchodilation and bronchoconstriction in terms of that. Well, there you go. I got ahead of myself. So there you goes that. Histamine receptors play a key role, especially in uh, allergy symptoms. Um, when we talk about histamine receptors for respiratory, we're talking about H1 or histamine 1 receptors that are found in the blood vessels, the bronchia, and the digestive tract. And then H2 receptors are just in the digestive tract. So we're not going to spend any time on H2 receptors, only on H1, and we're not going to talk about digestive tract unless it has to do with a side effect or a adverse effect. So sorry about that, blinking back and forth. Um, Histamine causes inflammatory response, um, causes vasodilation, and can be responsible for symptoms of anaphylaxis. Now, why do we care about that? Well, obviously, especially in environmental allergies, we tend to use an antihistamine for treatment. Um, but if we understand the reason that we want to use an antihistamine, we're going to see that the antihistamine is going to alleviate that local inflammation, and it does that in part by causing vasoconstriction. In the bronchial tree, um, histamine causes constriction and can be a player in an asthma attack. So again, antihistamine can reduce that at the very least, prevent that bronchoconstriction from occurring. The negative to that is that because of the drying effects of antihistamines, uh, we get thickening of secretions that are released or that are produced when histamine is released. So medications, we're going to talk about uh, a lot of several different kinds. Antihistamines or H1 receptor antagonists. Um, we have first generation and second generation, but they're typically the choice of drug of choice for allergic rhinitis. Most all of your antihistamines are best used prophylactically, meaning before symptoms occur. Um, but especially the second generation antihistamines, more importantly, are going to work better. So, this comes into play if a patient knows that every time the cottonwood starts to bloom, they get stuffy and runny and itchy and watery eyes and all the symptoms of allergies. They need to take that ahead of time. It can also be used for treatment of cold and sinus problems. And it's used a lot in over-the-counter medicines. Remember that especially the first generation antihistamines tend to have a sedating effect, and that's related to their anticholinergic properties. So the primary sedating antihistamine that most people are familiar with is diphenhydramine, also known as Benadryl. Again, this is one of those medications that we want to make sure we're using the generic name when we're teaching patients, because, like Tylenol, people are so familiar with Tylenol, they don't really know that it's called acetaminophen. People are so familiar with Benadryl, they don't really know that it's called diphenhydramine. It acts, of course, by blocking H1 receptors in the arteries, capillaries, mucous membranes. This is going to cause vasoconstriction. So imagine if your nose is stuffy, and part of that stuffiness is caused by inflammation and dilation of the vessels. That's one of the reasons why diphenhydramine can be used as a local decongestant. It's not really a decongestant, but because it reduces local inflammation, it has similar effects when we're talking about nasal congestion. It is sedating, but people tend to build a tolerance to the drowsiness, and so it's something that can be taken for a period of time. Occasionally people will have a paradoxical effect, and it can cause stimulation and excitability rather than sedation. It can cause cognitive impairment, problems with attention, memory, coordination, psychomotor function, especially in children and elderly, and if it's taken in an excessive dose. And then remember those anticholinergic effects. This is primarily where we get the drowsiness. We can get hypotension, tachycardia, and dry mouth. Usually these things aren't so bad that, compared to the allergy symptoms, people usually will tolerate these side effects. We would want to avoid anything that is sedating as well, so alcohol, CNS depressants, things like that. Diphenhydramine can be given IV, IM, or oral. It's available over the counter as an oral form. It's not available over the counter IV or IM, but you can do it that way. The second generation or newer antihistamines are less sedating. Fexofenadine, there's loratadine. I can't think of any of the others right now. But again, they are still H1 receptor antagonists, but they are less sedating. Some people are going to have sedative effects, but for the most part, they're typically not sedating. Sometimes they can cause a little upset stomach, and people can take that with food. Because they tend not to have the anticholinergic effects, they really don't have any medication interactions. We can also use a nasal sympathomimetic. This would be in the form of a nasal spray. And you can get several of these types of meds over the counter. Afrin is a popular one. These are alpha adrenergic, so again, they're going to, because they're alpha, they're going to stimulate the alpha receptor and constrict the arteries in the nasal passages, which is going to produce a drying effect, reduce the local swelling, and act as a decongestant locally. Overuse of nasal sympathomimetics can cause hypersecretion of mucus and a worsening of nasal congestion. So we want to make sure patients understand that they should limit the use to 3 to 5 days. Typically, adverse effects are local, stinging and irritation of the nasal passages. If used for a long period of time, usually more than a week, then patients can get rebound congestion. Or if they're using it more frequently than prescribed, or according to the directions on the bottle. So we want to make sure that patients understand they need to follow the directions and not overuse it. So it should be limited to 4 to 6 times a day, I believe. And if they do experience rebound congestion, they should stop using the nasal sympathomimetic. If it's bothersome, they can try nasal saline to help moisturize the nasal passages, and if that isn't enough, they can seek help from a healthcare provider and get some nasal steroids to reduce the inflammation. Now, typically these aren't absorbed systemically, but when patients use large volumes and swallow the medication because it runs down the back of their throat, they can get some systemic effects. And since it is a sympathomimetic, patients with hypertension, diabetes, heart disease, glaucoma should should take care when using nasal decongestants. So we want to make sure that we've evaluated for those conditions prior to suggesting the use of nasal sympathomimetics. Now, decongestants can also be given orally. They act slower because they have to be absorbed systemically. They're not going to act locally. So for that reason, they tend not to be as effective, especially for severe congestion. And because they are absorbed systemically, they are going to produce sympathetic nervous system effects. So with these, more so than even the nasal sprays, we want to make sure that patients don't have conditions that will be affected by the sympathetic nervous system stimulation. So again, hypertension, glaucoma, heart disease, diabetes, those sort of things. Patients need to know what kind of medications are considered oral sympathomimetics. Pseudoephedrine is one of the big ones. Anything that says ephedrine is going to be an SNS stimulant. Most of the packages are labeled such, but people don't always read. Phenylephrine is not as bad as pseudoephedrine, but sensitive people are still going to have spikes in blood pressure and the potential for pupil dilation, tachycardia that can occur with SNS stimulation. So they really need to be watchful. Pseudoephedrine and phenylephrine are very common ingredients in over-the-counter cold and allergy medications to reduce that congestion. They're often combined with an antihistamine or a cough suppressant, and so patients really need to be taught to read labels to make sure that they're not using medications, doubling doses because they're using 2 different types of medications. They think they are, if they're using 2 different brands or whatever, and to be aware of what the possible adverse reactions are. Intranasal glucocorticoids or steroids usually are used when antihistamines and sympathomimetics are not effective. The biggest problem with glucocorticoid sprays is that it may not work immediately, so it may take several days to see an effect. Typically, intranasal corticoids are only used for short term, so it decreases the risk of adverse effects. But again, there is still that risk. The most common effect is going to be nasal irritation and bleeding, but long-term use or overuse can lead to adrenal insufficiency. Prior to use of intranasal glucocorticoids or any nasal spray, patients should clear out the nasal passages by blowing the nose or whatever, preferably not using a sharp instrument or a digit. So blowing the nose would be much more effective. And they might consider using a decongestant prior to using an intranasal glucocorticoid as well. I think that's it on that. Cromolyn sodium nasal crom is a mast cell stabilizer, and mast cells are part of the process for histamine release. So essentially, it is an antihistamine. It just has kind of a little bit of different mechanism of action. Again, used for allergic rhinitis. It has to be taken before exposure, or it's going to take that much longer to work. Make sure again that they clear the nose before use. They're using a nasal decongestant or blowing their nose. Maximum, they need to know maximum 6 sprays per nostril per day to avoid serious side effects. The most serious is going to be bronchospasm. It may cause some nasal irritation and cough, and of course the cough could be because of bronchospasm. So they need to be aware of that. Again, usually not used alone, but patients need to be aware that it could take a while to see results, so they need to continue use even if it doesn't seem to be effective.